Hello everyone, and welcome to the third in our series of interactive webinars that we've been doing during the COVID period as a collaboration between the National Collaborating Centre for Mental Health and NCISH, the National Confidential Inquiry into Suicide. Sorry to introduce myself, my name is Tom Ayres, I'm the Director of the National Collaborating Centre. One of the, I think in my personal and professional life, the thing I've heard repeated most often in terms of people's concerns about the mental health impact of COVID has been the impact on children and young people. And I think people who've got children and young people in their lives or extended families will all have got experiences and seen some of the impacts of being isolated from friends, the disruption to education, and just living in this kind of slightly strange world at such a key time in terms of development and social development. And so there's a lot of people who are worried about this, and so I'm really pleased that we're going to be focusing on today's webinar on what we know about and what the impact is that we think on children and young people and what the risk is around children and young people during COVID. So I'll start by introducing the panel that are here with me today, then I'll just talk through the agenda and the housekeeping. So we'll start with myself, so we'll start with an awful photograph of myself. Apologies to everyone. So my name is Tom Ayres, I'm the Director here at the National Collaborating Centre. Really pleased to be joined again by Louis Appleby, who is the Director of NCISH Professor of Psychiatry and advises the government around suicide prevention for many years. And I'm sure everyone's familiar with Louis and his work over many years in this field. Really pleased to be joined for the first time by Nav. So we're pleased to be joined again by Nav Kapur, who works alongside Louis at NCISH as Head of Suicide Research, also as a psychiatrist in Manchester, and is a Professor of Psychiatry and Population Health. And finally, really pleased to be joined for the first time by Lara Ferguson. Lara is someone that's worked with us at the Collaborating Centre for a few years. She is someone who's got experience of using mental health services as a young person and an adult, and is now kind of developing her career as a researcher as well. We've just had a comment that the sound is poor through from people, so I'm not totally sure what we can do about that, other than to say that if the panelists, if we mute ourselves if we're not talking, that probably will help the sound quality, but we'll just forge on. Thank you to the people who are now saying the sound is fine for them. So onto the agenda. So we'll start with the welcome introductions, which we're almost at the end of, and then we're going to go to Louis, who will give a brief presentation about what we know about suicide risk in children and young people, and then we'll have a discussion about that. And I will say in a moment how you can join that discussion. We then will have, so that'll be about 20 minutes, and then we'll have about 15 minutes looking at how we measure and report the impact of COVID-19 on self-harm and suicide rates, and then the final 15 minutes again returns to a subject that regular viewers will know that we have returned to each time about how our mental health services continue to adapt, and perhaps how they should adapt in the view of our panelists during COVID-19. We are on Zoom today rather than Teams, so the ask and questions function works slightly differently. There we've got a Zoom a chat function which you can access, so it should be on the bottom of your screen with a little speech bubble and the word chat underneath it, and if you type a message on there, it will come to all of us, all of the panelists. So if you have questions that you want to ask, and we really encourage questions, if you type it there, all the panelists will be able to see it, but you as viewers, if you like, of the webinar won't be able to see it. So don't panic that you can't see it. We can see it as panelists, and I will try and collate the questions and make sure they're asked to the panelists as well. With the previous two webinars, I've had no chance at all of getting through all the questions that are asked, but I will do my best as ever, and we will share the slides with all participants. One of the advantages with Zoom is that you've had to register perhaps you don't see that as an advantage, but one of the advantages for us is that that means that we have your details that we can email the slides around afterwards. We'll also put them on our website. So without further ado, I'm going to hand over to Louis, who will start us off by talking about what we know about suicide risk in children and young people.
Tom, thanks very much, and good morning, everybody. Hope you're well. It's true that the subject that comes up most of all at the moment is the impact of the pandemic and how we've handled the pandemic on the mental health of children and young people. But it's important to stress that that isn't a new concern. That group, children and young people, were already the group that we were most concerned about in relation to mental health and suicide prevention. And the impact of COVID-19 has to be seen against what was already there, the background that already existed, and the concerns and the reasons for those concerns about suicidal behaviour in young people. What we need in the end is a new system of measuring suicide, monitoring it, known as real-time surveillance. So that's recording suicides as they happen without waiting until an inquest can take place, because inquests take place sometimes weeks, very often months after a death. They can't really feed back into immediate prevention. We haven't got real-time surveillance yet nationally, although we're nearly there, so that will happen soon. It's had to be set up in many parts of the country from a standing start in a way. We do have some real-time surveillance figures on the youngest young people, and I'll be talking about them a little bit towards the end. So this is the first slide. Why are we concerned about suicide in young people? This is the age and sex breakdown of suicide rates in England in the most recent full year, so that's 2018. It shows the long-standing pattern, higher rates in males, that's the blue bars, and quite a difference across the age range, with the lowest rates in people under the age of 20. So young people have the lowest rate of suicide of any demographic group. So why the concern? Well, first of all, because there is something particularly tragic about suicide in young people. There are around 200 deaths a year by suicide in the UK. So it may be the lowest rate, but that's not a trivial amount. 170 of them in England, thereabouts. Next slide, please. But here's where a lot of the concern is coming from. This is how suicide rates in the under 20s have changed over the last 20 years or so. And so if you look at the purple line in the middle there, that's males and females combined. And if you look at the second half of the graph on the right side, you'll see that there is a more or less steady rise over the last 10 years. So they may have the lowest rate, but they're also the only demographic group who have shown this steady rise over about a decade. And that steady rise probably started around, statistically, the turning point seems to have been around 2010. It's not unique to this country, but it does seem to be more prominent in countries where there is greater income inequality. So there's a clue maybe to causality. It's not necessarily the cause, but maybe a clue as to what social circumstances can make young people feel alienated and despairing. The slide also shows the male and female rates. Males, the green line there, and the female are the red line, and they're both going up, although it looks as if the line for young women, under 20 women, is a bit steeper, so a more recent rise, maybe suggesting a different pattern of risk. So these are the figures. They are the highest figures we've had for some time, about 20 years. The highest figures for about 20 years, and in the case of females, about the highest figures for about 40 years, since ONS, the National Statistician, began collecting figures on specific age groups. These are the people under 20. You get something similar in people in their early 20s, but with a more recent upturn in the numbers. Again, the highest figures for about 20 years. Next slide, please. So what are the possible causes of rise? And to answer that question, we have done a study in our research group where we collected information from coroner's inquests and from national reports, investigations carried out locally, other official sources, on all deaths by suicide in people under 20 over a 3-year period. And across the UK, that was around 600, just under 600 deaths. It's worth pausing for a minute on the individual tragedies that lie behind these large figures. These are 600 lives needlessly lost. So we looked at the things that were happening to people, the antecedents, the precursors of death. What was going wrong? What were the stresses in the lives of young people across the country in the period leading up to suicide? Now, the first thing we were able to report, that's the graph that's on the slide there, is a very marked effect of age within this group under 20. So it's very obvious there. The suicide in the under 15s is very unusual, but rises very steadily in late teens until by the end of the teens, the rates are more or less at adult levels. That rise, that escalation in the late teens is not seen at any other time in our lives. It's something is happening in the lives of young people that make that put them at a particular risk, and we have to understand what those stresses are. The stresses were numerous. Some started early. Sometimes people had been through difficult family circumstances, difficult relationships at school, victims of bullying, for example. But they also included bereavement and suicide bereavement in particular. About one in 11, I think it was 1 in 11 of the young people who died had a bereavement by suicide that was still thought to be affecting them. That sense of a chain reaction, impact of one death on another person. There was quite a lot of physical ill health, not necessarily life-threatening ill health, but socially limiting ill health, health conditions, kept people away from their peers. And there was, in about a quarter of cases, young people had used the internet in a way that was related to suicide. Not just social media, that's a story that's out there, but it's quite simplistic, really. Very often it was about searching the internet for suicide methods. The risks of the internet are not just about social media. It's partly about the information that you can find there. About 40% of people had some kind of contact with child-related services. This is not just CAMS, this is any child service, social care, youth justice, which means that the majority of people in the period leading up to suicide had no contact with any specialist child service. One more thing to say about this, of course, these are the clues to prevention. The one thing to say about it is that a lot of these factors were more apparent in girls. So again, that sense that there was a difference between the sexes. Next slide, please. So it's important because the rates are rising. It's important because there seem to be some child-related factors, things going on in young people's lives that we need to intervene over as a society, but also because of what we're seeing in self-harm rates. So this is a study now from a national survey, the Adult Psychiatric Morbidity Survey, quite a well-known regular survey nationally. And we did some work with them on self-harm rates over the different time points when this national survey has been done. The survey asks people about their mental health. It asks them about self-harm, lifetime and recent self-harm. So the two graphs on the screen, males on the left, females on the right. Let's look at the one on the right. And the different colored lines represent the time points when the survey has been carried out. So the most recent of the surveys was actually done in 2014, although it was reported in 2016, and this result was only published last year, so it's a very recent finding. And you can see what the slide is showing. It's showing, first of all, that self-harm is much more common in the youngest group. Now, just to point out that this time the youngest group is a different age group, so we're now talking about not the under 20s, but under 25s. But they had the highest rate. And not only that, but if you look at the way the colored lines are changing, the rates have risen. So over about 20 years, we've seen what looks like a substantial, incredible rise in self-harm in young people, particularly in young girls. So again, that sense that there is perhaps some kind of sex difference. This is the kind of thing that makes us concerned because it implies that self-harm is being, people are turning to self-harm more when under stress, and that has long-term implications. The fear is that young people acquire self-harm as a way of coping with distress, and that once they get into older, more suicidal age groups, that will translate into fatal self-harm. Final slide, please. So plenty of reasons to be concerned about the background against which COVID is having an effect. So now this is the study that we've recently reported, where we've actually looked at suicide rates since the pandemic began. This study was carried out with, it was led by the National Child Mortality Database, based at the University of Bristol, who collect information on all deaths by people under the age of 18. And for this study, they looked at deaths which were likely to have been suicide, not post-inquest, but real-time surveillance. And what we found was that in the 8 weeks that corresponded to lockdown, there appeared to have been a rise in child suicide. So during that time, it's worth saying that even though there was an apparent rise, the risk was still low, so it hasn't changed that demographic fact. And because overall numbers are pretty low, and we're only talking about an 8-week period, the numbers were too small to be statistically significant. So in other words, in the jargon, the confidence intervals were wide. Although there was a rise, it was possible that the numbers hadn't gone up. It was equally possible that there'd been a substantial rise. That's how confidence intervals work. So the range of possible conclusions was quite broad, but there was a signal, as we called it in the report, a concerning signal that child suicide may have gone up in relation to lockdown. About half the people who died it was reported that there were factors related to the pandemic and to the lockdown period, becoming more isolated, disruption to care, disruption to education, tensions at home, contributing, it seemed, to about half the deaths. It was also apparent that, or at least it seemed, that people with autism, autistic spectrum, ADHD were overrepresented, so that there was a concern that that group is at particular risk. But there wasn't a rise in that group post-lockdown. That risk was just as apparent pre-lockdown, and it's probably a feature of child suicide in general, and something we should be concerned about. So the conclusions of this work, an alert to the system, an alert to services, but not conclusive proof, just an alert that we should be worried about. We should take care over young people, their mental health, their risk. We should be, as a society, as a service, we should be vigilant. We should make sure frontline staff are aware, and we should pay particular attention to that autism ADHD subgroup. Thanks for listening.
Thank you, Lewis. That was really, really fascinating. And we've got quite a few questions that have come in. I just want to ask, before we go to the panelists, a couple of hopefully very quick clarification questions, Lewis. So first of all, can I just check that the last slide that you talked about with the looking at the increased risk or suicide deaths through lockdown, that those figures come from the real-time surveillance systems that we have in place, which is not a full picture of the country, but which we have at the moment. Is that correct?
No, sorry, I didn't explain that very well. We're aiming to have real-time surveillance for all ages over part of the country, a representative part of the country that will give us high-quality data. This comes from a separate real-time surveillance system set up about a year ago, concerned with child mortality. It's not specifically about suicide, but it does collect deaths in under 18s by suicide. So we took advantage of the existing database to answer this question.
Okay,
so that's complete national figures is the point. Complete national.
Yeah, that's very helpful. Thank you. And then the slide, which I think a lot of people are interested in, with the looking at the different kind of risk factors, or the factors in death. We've got on there 40% of people had no service contact, and I just want to check that is 40% of the 595 suicides within that sample. Is that you're talking about with had no service contact, or is that a wider figure? So
there were 595 deaths altogether, and we were able to collect detailed data through through inquests and other reports in about 90% of them. So it was something like 540. So it's quite a big sample, and that figure, 40% had no service contact at all of any kind with child-related services, and 60% had no recent service contact.
Okay. Okay. So 40% had. It's confusing. It's like, that's probably what's slightly confusing is the numbers. 240s, yeah. So but they're measuring different things. So 40% no.
Slightly different. So the overall figure was that no contact with any service that dealt with children was 40%.
Great. Okay, thank you for that. Okay, so there are some really interesting questions which I'm going to move to in a moment. But I thought before I do that, I just wanted to go to Lara on the panel and see if I can just ask Lara for her reflections on what Louis has said and I guess her thoughts on the subject in general.
Hi. I think hearing those numbers really put things into perspective, and it was quite sobering to see that they're not just figures, they're real young people who've lost their lives due to suicide. I think it really highlights how much further we've got to go to prevent this. I think my biggest cause for concern during lockdown is schools closing and the consequential social isolation for young people. I think this is particularly important now we know that 40% of young people who died by suicide didn't have access to services. I think schools can act as very kind of protective kind of environments for young people. Not only they've got friends and teachers and social networks, but also kind of distressing symptoms can be picked up by the schools and noticed. And from personal experience, I think schools can be quite attentive and aware of changes in behaviour that could kind of highlight that young people are really struggling. And the fact they don't have that now, I think is really distressing and really kind of important to pick up on, because these young people haven't got anywhere to go to, but also they haven't got anyone to notice that they are becoming increasingly distressed.
Yeah, thank you, Lara. That's really interesting. And I'm just to Nav, I guess, just thinking about what Lara just said, but also which also chimes with the 60% of people who've had no recent service contact, and we've got a question about a recently published paper. Sorry, it's not a paper I've seen, but saying that a third of children and young people exhibited no signs of distress to their family, presumably prior to dying by suicide.
Yeah, I think it's
Yeah, so I'm just going to ask for your reflections on that, I suppose.
Yeah, I mean, I think you know, there's a kind of essential paradox here that I think is worth just highlighting for a second. In that young people are the group who are least likely to be affected by the physical consequences of COVID-19, and yet arguably they're the group that will be most affected by our mitigation strategies. And for me, that's an example of kind of society at its best, you know, people pulling together to protect the most vulnerable. But we've got to be mindful of the mental health burden on young people. My colleague Ellen Townsend in Nottingham talks about them being a neglected group. People have said, you know, young people feel left out of the COVID-19 conversation. And research out there is quite sparse, both in terms of kind of service contact and non-service contact. So there was a paper out this morning showing on average a 10% worsening in mental health during the early part of lockdown. But the group that were most affected in that longitudinal survey were young people aged 18 to 24. And reflecting on Lara's point as well, there's a difference between younger kids and older kids. So there was a study from Oxford, the CoSpace study from Oxford, which showed that it looked like emotional problems were worsening in primary school age kids, but actually emotional problems were a bit better in secondary age school kids. So the effects aren't uniform. And if you like, you know, you've got those kids who are in mental health service contact, and then you've got the kids who aren't. And for the kids who aren't, if you like, one of the main routes in would be through schools, and obviously they've been kind of closed. So I think, you know, moving forward, that's going to be a real opportunity to hopefully think about what we do for prevention going forward.
Now, what do you think that? So I think listening to the webinar, we'll have people from a broad range of areas, but there will be people from public health, ambulance services, mental health services, police, local authorities, schools, I hope, as well as probably children, young people, and carers and so on. What do you think that people can do? I mean, it feels just quite, there's this, you know, there's a lot of people who are just maybe going under the radar, and even more, like you just said, the risk of that's even more so during school closures for most children. What do you think people can do at the moment, as we're just entering summer holidays as well?
Yeah, I mean, I think one of the things we have to think about is what's different about preventing suicide in young people from everyone else. So we all know about our general suicide prevention measures. Many of the people, viewing this webinar are very active in that. And it's about thinking about what's different and what we can do about suicide prevention in young people specifically. One of the things is about self-harm. So self-harm's a more common antecedent in young people than in older age groups. So thinking about that, some of the self-harm will present services, some will not. Thinking about providing evidence-based interventions for people. Obviously, I've got 3 kids at home. The role of parents during this time is especially important. So, both in terms of picking up any emotional difficulties, but then self-harm comes to light, thinking about what might happen there, and also thinking about, I suppose, for young people, how they consume media as well. The media can be a force for good and a force for ill in terms of kind of mental health, and young people, as Louis has kind of said in his presentation, consume media in different ways. There's some of the kinds of things we need to be thinking about, but I think things are changing quite quickly, and when schools are reopening in September, hopefully things are going to get a bit easier.
Yeah, although I think a helpful comment that we've had through that, actually, it's a mixed bag, if you like, that there are children who have really struggled with school closure and isolation and lack of social contact, but there are other children who actually are feeling really quite anxious about going back to school and have done quite well with life away from school. So
absolutely, it's a real. I think that's a really important message, that the effects of this aren't uniform by any means.
I also think the problems won't stop once schools are back open. I think we need to really look kind of long term with this, because these disruptions are going to continue. Young people who are currently sitting their GCSEs have kind of no closure on the next steps. People going into university, social relationships have all been disrupted. So I think schools reopening for many young people is the start of normality. But I think it's going to take a long time to get back into kind of that supportive, positive environment for people.
Yeah, Tom, can I say, I think that's a really important point, that we are quite at the moment preoccupied with the immediate effects of the pandemic, so the acute pandemic and lockdown and school closure, and that's understandable. That's the situation people are in. But long term, the effects of COVID-19 will also be economic, and they will affect opportunities for young people, perhaps particularly. And so some of the biggest risks will be when people take that step out of school into employment and further education, because what's waiting for them may be less of an opportunity than they would have anticipated. And that initial step, the evidence is the economic evidence, not just the mental health evidence. So that initial step is an important one, that if you don't get into the kind of work and education that your skills might have predicted, then that can have a long-term effect. It means that you don't acquire the further skills that you need to succeed in the job market. You don't get the experience that will take you a step on into your next professional role, and so on, so that your earnings are less. And if your earnings are less, that has an effect on your life chances. It affects who you meet. It affects your ambition for yourself. And so the long-term economic consequences are the other area that we will have to address. And that's particularly for young people who are a little bit older than the group I was describing, just stepping out from education into the sort of wider occupational world.
Yeah, thank you, Louis. Actually, Louis, I was going to come to you to ask a question a couple of people have asked, and I've seen this slide a few times, about the suicide rates for 15 to 19-year-olds going back to the year 2000, and have wondered, and never asked you actually. There was a real peak in the early 2000s, particularly in 2001, and particularly in males at that time. Do we have any idea what that was about, and is there any learning from that we can take now, or the current situation?
Well, the slide starts around about then, but it wasn't so much that there was a peak around then. It's just that the rates in the 1990s were in young people were generally higher, and in fact they had risen towards the end of the 1990s in young people generally, not just in this youngest age group, but in other younger groups as well. So I think what we're really seeing is that we saw a fall. The thing that's on the slide is a fall that happened from a previous high rates. That's the striking thing, and that tremendous benefit where we saw suicide rates go down during the 2000s to a point towards the end of that decade where they were at historic low levels in this age group and in others. It was then lost, and so that rise began to occur. The rise that's on the slide began to appear. So I wouldn't be too concerned about the beginning of the slide where the rates appear to just peak slightly. What that's really showing is that we used to have higher rates in young people, but we seem to get over that, and now they've come back. Okay,
that's really helpful. Thank you, Lara. If I just come to you again. We were talking earlier about the people not accessing services and that being a bit of a feature, and there were a couple of questions for you around, or in the comments on one specifically around, I guess, accessibility of services and in other health services such as, I suppose, GPs, A&E, ambulance services, and paramedics, about what they can do when they are attending to young people in mental health crisis or after self-harm or something similar. I suppose my question to you is, what do you think from your experience it's about the fact that people, children and young people don't seem to be accessing, or a lot of the people who died didn't access mental health services recently, so most of them hadn't had recent contact with mental health services. There are some simplistic answers to that about funding and about accessibility, but I just wondered if you, which may well be key factors, but I wondered what your kind of views are on what that is and what services can do.
I think there's kind of two main aspects to that. I remember being kind of in that age bracket, and my mental health was very up and down, and one day you'd feel perfectly fine, and then the next everything would feel impossible. And I think it really highlights the need for a kind of population health approach to mental health, because we all have mental health, and some days we have poor mental health and some days we have good mental health. But if across young people we provide the skills and coping mechanisms needed, then on those darker days people have those resources already there to kind of prevent things turning into self-harm or suicidal behaviours. I think that's kind of something moving forward is really important. And I also think schools, more than mental health services, play a big part in that. And I think the other thing as well is young people don't always have the language to talk about these things with families, carers, schools, or professionals alike. I think there's a lot of still, although we're having these conversations, ingrained stigma, which makes it really difficult to kind of be honest and open. And that's even more important at an age where you're forming kind of social relationships and building up your place in the world. You don't want to always come forward as the person who is self-harming or feeling suicidal. And it's kind of getting to that point where it's okay to talk about these things and not have that embarrassment, which really does come from within.
Yeah. So I just add to that, I think that it's a very important point about the fluctuating mood in young people sometimes when they can be at risk. I think somebody asked a question, I think that was what you were reading out, about our paper showing that about a third of young people showed minimal warning signs. One of our papers actually came out a few days ago. And the message of that paper was that when we are talking about young people, some of the rules of risk assessment and risk recognition don't apply because young people's emotional responsiveness is still developing. It's often not the same as the way that we've got used to with older people. And so we can't assume that, for example, that we're looking for mental illness in the traditional sense. That's often not the thing to look for. So when we're talking about people not making contact with specialist mental health services, that's maybe because they're not really experiencing the kind of sustained severe depression, let's say, that you would expect in an older person. And so as a society, as families, as friends, we have to be vigilant about that fluctuating mood that young people can experience when they get into crisis. That sense of being okay one day, but the next day facing real difficulty. That's not an easy thing for us for others to be able to spot. And unfortunately, I've met so many parents who have said that, you know, they were with their son or daughter and they seemed fine. And then a couple of days later, they took their own life. And it's an absolutely tragic story, because they felt they could have done more if only they'd known. And historically, we've always thought, well, maybe it was a matter of concealment. Maybe people, they didn't want to talk, and so they weren't really. And of course, there's bound to be some of that. But I think it also tells us something about the changeability of young people's mood in response to the stresses that they're facing day to day. And we have to be alert to that and give them the skills to respond to that changeability, to know what to do in a crisis, to recognize it in themselves.
Yeah. Thank you, Lewis. That's a. I feel like we could continue the discussion to be entirely about this subject until 11 o'clock and beyond. We've got other things on the agenda, so I'm going to move on now. But I think that kind of last summary there from you was a really kind of helpful place to kind of part of that discussion a bit. We'll probably come back to it during the next 20 minutes still, or 25 minutes. The next item on the agenda is about measurement and reporting of suicide. And particularly the impact of COVID on self-harm and suicide rates. And I think probably most people will have seen some level of reporting in the media about some quite alarming figures, which I think are not, you know, from what Lewis has been saying today, are not the case, and not something there's evidence of, but there's certainly a lot of reporting about this. So I wonder if I can start with Nav, perhaps, to start the discussion on this one.
Yeah, I mean, most of the speculation has been, you know, frankly, unhelpful. And I suppose when some of you will have the iceberg model of suicidal behaviour before, with, if you like, suicide at the top as the most kind of serious consequence. And you know, in terms of real-time data there, we've obviously had the national child mortality data that Lewis has talked about. We've got this system that's being set up of real-time surveillance. It's selected volunteer sites around the country who will feed in their data centrally to Public Health England, and hopefully that will get going within the next couple of weeks. But we don't have definitive data on what's happening to suicide rates at the time of COVID. If we go further down the iceberg, if you like, we know a little bit about hospital-treated self-harm. So that's people who have hurt themselves and presented to hospital, and data from at least 3 different sources. So that's the multi-centre study, the emergency care data set, which is a kind of routine data set, and a selected number of liaison psychiatry services around the country, suggests that shortly after lockdown, in common with many other presentations, people were less likely to come to hospital or to present with self-harm. So not to say self-harm was becoming less common, it was just that people were much less likely to attend services. The next level down in the iceberg, if you like, is community self-harm, and we've not got a huge amount of data on that before and after lockdown. We've got some quite good population data to monitor kind of self-harm, people self-reporting self-harm during lockdown. And that really seems to have stayed at a fairly constant level, but rates of self-harm in young people are higher than in older age groups. But again, no clear signal there that rates have increased markedly. But what you've got then is rates that we don't know whether they've gone up. They certainly haven't gone down, but people are much less likely to attend services. So the question is, where are people going if they're in distress or self-harming? So colleagues in the third sector, mental health charities, are telling us that's where you know, the unmet need is being met. So figures from some of the charities is showing big increases in help-seeking behaviour. Now, obviously, that's not self-harm or suicide, but it's an indication that, you know, the distress is still there and people are presenting in other ways. So the data picture is by no means kind of clear at the moment.
Sorry, I'm using myself. Thank you, Nav. Lewis, I wonder what your comment on this subject is.
Well, Nav summed up pretty well, actually. It isn't straightforward, though, getting new data. The real-time surveillance systems are complex, and to work properly, they have to be comprehensive. So the biggest question that they can answer for us is, has there been a change? And you can't answer that question unless the system is comprehensive. It can also serve as a bereavement support system, so that if you're monitoring suicides closely, you can also provide better bereavement support to people, to families who've lost someone. So it does serve a dual purpose, but that comprehensiveness is a statistical necessity if we're to understand what's happening to rates. I think we will. It will help us to have real-time surveillance. It will never answer every question that we have, but it will tell us some quite important questions about what's happening to rates, but also about who's most affected. We'll hope to be able to draw conclusions about mental health care and how we can strengthen it. We hope we can comment on population subgroups. Great deal of concern about ethnicity at the moment and its impact of COVID. So we should be able to look at that too. But I don't, at the moment, know of any country in the world that's managed to set up a real-time surveillance system since the pandemic started. And you know, it's just a reflection of the fact that it can take some time. Yeah. What we know at the moment from more informal communications with local areas is that there doesn't seem to have been a big rise. And so my concern about media reporting, where quite often we're seeing it's almost like a competition in the media to see who can report an escalating suicide rate first, has led people to produce some unhelpful reports about figures. And I just hope that people out there realise that we don't have figures yet. We don't have reliable national figures yet. So anybody who is publishing what they claim to be indications of suicide are not publishing anything reliable, and not to be too influenced by them. It's not just a question of accuracy, though accuracy counts. It is also about alarming people who are potentially vulnerable. If you're distressed and struggling and lonely, and you hear that that's the sort of person who is really finding it difficult and at risk, then that can be bad. That sense of identification with somebody who has died and the kind of people who are most affected is potentially harmful. So it is very important that we don't get that kind of reporting, or at least understand its limitations when we see it.
Yeah, yeah. Lara, I just wonder, from your perspectives, and perhaps from people you know, seeing some of this reporting, how do you what impact do you think that has on young people? I presume you've seen some of the reports in the media over recent times, although it's not a particularly new phenomenon to be alarmist about this sort of thing. What's the impact that you feel that has on young people?
I think objectively we know that irresponsible reporting of suicide leads to spikes in suicides. So I think media outlets are really conscious of that. But on a personal level, it really hurts. I've lost quite a few friends to suicide over the past 5 years. And every time I see those articles, it's a constant reminder. And that's for me as a friend. And I can't even begin to imagine how it must be to be a parent or a family member or relative of someone who's lost their life to suicide. And I think also young people who are struggling themselves, you see these things, and you can be, watching TV, watching something really, really trivial, and then news articles pop up about these things, and it instantly puts the idea of suicide back into your heads. Thoughts about self-harm come rushing back in. These are things that you haven't been thinking about. It's this constant kind of triggering over and over again. And I think eventually it does wear people down. And also those people who are maybe kind of teetering on the edge of dangerous behaviours, these thoughts can then be enough to kind of push them into acting on previous thoughts. So they need to be really careful.
So that touches on quite an interesting question I think we've had from someone about talk. So you said there, Lara, that seeing these reports in the media, particularly alarmist ones, but even if they are accurate reports in the past, it can kind of trigger thoughts and put ideas in your head that hadn't been there at that moment. There's a question here about, again, kind of getting at that issue that we talked about being able to talk to people, being vigilant, and families and friends and schools being vigilant about people's mental health and talking to young people. And the question is, I'll read it. So I'm interested in the premise of it as well. So how can we approach suicide prevention in young people when all the advice we get from academics is do not talk to them about suicide and self-harm, as you might actually make them think about and carry out suicide or self-harm. So it's linked to what you're saying about reporting there, Lara, but not exactly the same, as this is about individual conversations. But I just wonder what your thoughts on that question. First of all, I'm going to go to Lara and then come to Nav and Louis on that question.
I think it's really interesting, actually. I think if young people are already having thoughts of self-harm or suicide, these are conversations they need to be having, whether that's with professionals or loved ones. We need to be talking about this and working out why these thoughts are happening, but also how we can kind of mitigate them and make things more safe. But I think the difference is with the media is that we're being bombarded by information, statistics, and it loses its compassion. It's not happening in a controlled environment, whereas if you're having a discussion with your family, it's at a time where it's safe and feels appropriate, yet we can't choose when we switch onto the news and hear these things. So there's kind of a big distinction between the two. But for young people kind of experiencing these thoughts already, I think conversations are one of the most important things that can happen.
Thank you, Lara. I think the word compassion was really important there as well. Nav, I think it looks
Yeah,
like you wanted to say
I think
something about this.
No, I think it's really important to say that you know, on an individual level, a family member or a professional talking to a young person about, you know, some of the thoughts they might be having, ideas of hurting themselves or ideas of suicide, will not put the idea into their heads. The overwhelming you know, feedback we get from young people, from all people, is actually that's helpful. You know, that's helpful, and we do need to talk in those terms about suicide, and that's a really important kind of destigmatizing message. I think the difficulty comes when, you know, the message either becomes through the media normalizing, so you know, self-harm as a normal response to distress, and you know, some of us think that might be responsible for some of the increasing rates of self-harm recently, the kind of this kind of normalizing function, or when the media kind of sensationalize kind of self-harm or suicidal behavior. Those things, we know the evidence is very clear. They if you like, propagate suicidal behaviour, they make suicidal behaviour more likely. So there is this bit of a balance between destigmatising, that, you know, just to stress, talking on an individual level is fine, and most people experience that as helpful, versus normalising or sensationalising, which, you know, is primarily a media function and is frankly unhelpful.
Thank you, Nav. That's a really helpful answer. Louis, I'll just give you the last word on this subject about measurement and reporting, and possibly the discussion we just had as well.
Well, it's quite a good question, actually, because I can understand people saying, well, are people influenced and made more at risk by the conversation going on around them, whether that's in the media or whether it's among friends, or whether it's being asked a question by a parent. So these are different things. I think we just need to make sure people got that there's a difference between media reporting, where the problem is a person who is already distressed identifying with the presentation of suicide risk, and that identification is encouraged by the way that reporting takes place, by the sense that that there was some logic to feeling suicidal, if you like, that it was a kind of inevitability for someone in that situation. And a person who's already distressed, who sees that message, that this is what happens to people who are like me, that's potentially a very damaging thing, and the media have a responsibility that, I should say, just to be clear, most journalists do observe the media guidance quite well, but there are regular lapses, I'm afraid, but most journalists do their best. It's quite a different situation to when we're talking about the need to give young people the opportunity to talk about how they're feeling. That's another situation. That's about creating the right circumstance for distress, and for distress to be open and responded to. In our study, you could say that a lot of things we reported as antecedents for suicide were not very unusual. They're things that happen to a lot of young people: bullying, some difficulties in the family, academic pressures. Those are common things. And the message of that has to be that that when people are distressed over those things, we take it seriously. We don't dismiss adolescent or young people's upset as if it's you know, a phase or something they'll get through, or nothing that we should be too worried about. We take it seriously, and we take it seriously in everybody, because amongst all the young people who might find that those areas of distress are some who might be particularly at risk. So it's that opportunity which will protect the small number of particularly vulnerable people.
I think one of the issues at the moment is the fact that these kind of common everyday occurrences that do cause distress are being dismissed. And from personal experience and speaking to so many other young people, they are kind of trivialized and seen as little issues. You know, bullying is seen as, oh, well, everyone's bullied, or everyone has friendship issues during school. And actually now we know that these cause real issues, and they do push people to take their own lives. I think in services, we really need to look at now how we can not invalidate people's experiences, but make them know that they are important and they are serious. And I also think that comes back into families as well. When young people are going through what are seen as ordinary young people, difficult periods, we need to recognise that they are risk factors. And while many people get through them fine, some young people don't. And if one young person really struggles with one thing, then that's enough of a reason to take it seriously for all young people.
Yeah, brilliantly said, Lara. And just, I'm going to stick with you as we move to the last point on the agenda. We talked about it a bit already, but how are mental health services continuing to adapt during COVID-19? And perhaps implicit in that question is, how should they adapt? So, Lara, I want to start with you for this section, please.
I think I've spent the last 5 years advocating for services to move online and to go virtual and to have the opportunity. And now it's here, I'm left feeling really uneasy. I think it's great that young people have the choice for virtual appointments. What I don't agree with and don't think is appropriate is the fact that many services have gone totally virtual. And I know that there was a time where this was needed and this was the only safe option, but now I think the key word is choice. Do young people want to have telephone appointments, or do they want to be seen in person? And I think this kind of blanket rule of everyone is seen virtually is really damaging, because it means that young people who aren't confident talking over the phone or via video call, when they drop out, they're lost. And these are young people who now don't have their usual support networks of schools, friends or family, and they're left with nothing. So I think we really need to work out how we can build this element of choice in there. And I also worry that young people who are at home stuck in their families can't talk openly or honestly via video call or via phone calls. I'm the most awkward person when it comes to phone calls, and I consider myself rather confident. And I still love to go and walk around the block taking any call, because I hate the idea of other people listening in. So I think I really worry about how people who are confined in family environments can talk openly about their feelings, and that the effects that this is going to have long term. I think moving forward, we need choice, the option, but also looking at if video phone calls are working for people, how can we continue that after the pandemic?
Yeah, that's really helpful. So it's almost, there's been a great rapid adaptation of to the circumstances, and great leaps forward with that. But I think the message is, but choice is needed, and don't kind of move wholesale.
The choice of treatment as well. I think activities like group therapy or peer support kind of dropped off the network, because now it's focused on one-to-one kind of support and guidance, and that's not always what young people want or need. So it's not just the method, it's not just the delivery of the support, it's also the type of support we need to really consider. Yeah,
I think that's an interesting point about peer support, and the importance of that. I think it's something in mental health services for all ages. It's becoming more and more part of what services can and should offer. But I guess for young people, that perhaps feels particularly critical, the peer group providing positive influence in that way. Nav, what are your thoughts on what Lara said, or the subject in general?
Absolutely, you really kind of expressed it so well, Lara. I really like that. I mean, what we've talked about a few times at these webinars is that is this very striking thing that happened in mental health services during lockdown, which is a kind of decrease in activity, a decrease in kind of physical face-to-face, and move to online. So decrease in activity in some ways, but an increase in acuity. So the people that were presenting face-to-face were more unwell. I mean, we've also talked a little bit about how services around the country have responded to the challenge. What a great job many services have done in changes that were, normally would take years, instituting them in days and weeks. I think though it's really helpful focusing on where we go from here actually now. And there was a really interesting paper published in the Lancet Psychiatry about 4 days ago, and it had lots in, but I took away a few things from that. Going forward, what we shouldn't do is abandon our kind of core principles of service development. So co-production, making sure that we're measuring outcomes, making sure that the treatments we use are individualized but kind of evidence-based, using what works. So don't abandon the core principles going forward. And the other thing that was in this paper that I really liked is don't try and do it on the cheap. So these kind of changes, these developments need to be kind of adequately kind of resourced. And I think that's quite helpful moving forward. People in mental health services talking about kind of more normalizing services, but some services are never going to be the same again. And I love Lara's point about, well, what we need here is kind of choice, and the service user voice. We've done that for years in mental health services. We should continue doing it going forward.
Yeah. It's been a bit of a theme I've heard generally around what's happened in lockdown is that there is a threat to multi-agency working, or there has been a threat to multi-agency working in some people's opinion, and by the kind of very fast, almost command and control management of some of the changes that was needed. And there have been some comments in the chat on the webinar about the importance of multi-agency working around, particularly in suicide prevention. So I just wonder if Louis, I don't know if you had any thoughts about if you had any reflections on whether that's been a particular problem during lockdown around multi-agency working or partnership working and that sort of thing, or anything else about mental health services.
I think the first thing to say is that we should be prepared to learn as we go. We don't really know a lot about how services should respond in this very unique situation, and we should be learning as the situation unfolds, and the people we will learn from are young people themselves. There's always an irony about having people like me pontificating about young people, I think you hear Lara talking about, you're getting the authentic voice there of young people. I think that's absolutely crucial. A lot of places don't have a forum for that to happen, for young people to give their views and make their requests and express those choices, and that should happen locally. It should happen at a national level too, but we have a way to go before we're doing it properly. So learning, I think. I think there is a question about mental health services not just responding in themselves, although there are some indications of what they should do. After all, we know that the people who are most anxious during lockdown are people who are lonely. So dealing with that sense of isolation, making contact with people who would otherwise have lost their contacts, lost their supports, that's crucial. Being concerned about certain groups of people. I mentioned already people who are in autistic spectrum and ADHD young people. So there are already concerns that we can respond to. But the task is often multi-agency. I agree. I don't know exactly how difficult that's become, but the task is certainly one that isn't just about clinical care. It is about the broader life problems that young people might face, which, as I said right at the beginning, building on what they were already facing, and how that COVID will develop and enhance and make worse for some people the things that they were already struggling with. And that's a multi-agency task. It's about partnership with the voluntary sector. They're a very important source of support, and that they need to be brought in by the NHS, recognised for what they do. And it is also for whole communities. This is about also about community response and the strength of a community, how we hold ourselves together, how we build up the ties that bind us. That will also benefit us all, but benefit young people in particular. And one final thing, I just want to make sure that when we're talking about therapy and what services do, and psychological therapies and all of that, that it has a purpose, that it is that we're conscious of some of the big steps that young people will be taking with their choices about education and about working and about training and apprenticeships, and that the therapy that is not just therapy, it's about helping people make the right steps in life. And When we set up psychological therapies in the 2000s, that was the intention. It was to make sure that it was linked to helping people get work, fulfill their educational ambitions, and so on. It was more than just, I don't mean just, but it was more than getting beyond people feeling depressed and anxious, but it was making sure that that depression didn't hold them back when it came to making life choices and life successes. So linking the clinical service to broader economic and educational improvement, that's what I would like to see services do.
Thank you, Louis. That's great. Really sadly, we're out of time. We could go on for a lot longer, I think. As ever, I want to, well, actually, before I do that, so there's been a fantastic set of questions in the chat. There's been some requests for sharing of articles, and there's been people asking to be put in touch with people. We will do our best to collate that, share what we have, and people in touch. Luckily, we have everyone's email address from the registration with Zoom, so we will be doing that over the next week. The webinar will go on to be put onto YouTube within a couple of days, and that will be on our website as well, and we'll send the link of that to everyone. As ever, I want to thank Nav and Louis for their fascinating contributions today, but with respect to them, I want to read out one of the comments that has been made and echo that, which is, can we thank and congratulate Lara for compassionate and insightful contribution today. Well done. And there's actually been quite a lot of people in particular wanting to thank you, Lara. So I want to echo that and say thank you so much. And I'm going to give you the final word for the webinar before we say goodbye to everyone. And before that, I'll just thank everyone who's been watching. And we hope to see you again soon for our next webinar in about 6 weeks, I guess. So Lara, over to you to end the webinar in any way you want.
No pressure. I think my take-home message would be that when we see numbers every day in our professional and private lives, it's really important to remember that these numbers are people. They're real lives, real friends, real people with futures and ambitions and hopes and dreams. And that's what we're working towards. We're not working towards reducing numbers. We're working to saving lives and giving people hope and giving people a future that they deserve.
That's fantastic. Thank you very much, Lara, and thank you, everyone.